Hello, I'm Dr. Marco Gabriele Raddi. I work in Florence at MDS unit, University Hospital of Careggi, Florence. I'm collaborator of Professor Santini, so my focus is mainly on myelodysplastic syndrome patients. And I actually developed an interest in the lower risk forms of MDS, especially in clinical and translational research in the treating of anemia in low-risk MDS. So both clinical research and clinical trial as well. So this work born with the idea to try to identify more specific predictor of response to the standard treatment, which is erythropoiesis stimulating agents. But right now, the current landscape of the treatment of anemia in low-risk MDS is changing, given the approval, first of all, of luspatercept, also in the first line. So since the treatment is becoming heterogeneous and being MDS an heterogeneous disease, we wanted to dissect the different features from the molecular point of view to the erythroid population point of view to see whether we could better predict the response to ESA in the case of this work. So we collected flow cytometric data and molecular data from our patients, around 100 cases. And we investigated the repartition of the different erythroid subpopulation, given the fact that ESA acts on the early stage of erythropoiesis. So we wanted to see whether responding patient display an increase or something that could explain their response compared to non-responder. So, in addition, we also included molecular data, mainly with targeted next generation sequencing, because this is a procedure that right now is incorporated in the diagnostic evaluation of all MDS or suspected MDS cases, and also to integrate this information in terms to the ability of predict as a response. And we found some interesting results that show that patients who have a sustained response, this is the main finding of our study. So longer response was defined as longer than 24 months. They have a significant increase in the expansion of the immature erythroid precursors in the bone marrow at baseline, so before receiving treatment. And this precursor can be easily recognized with flow cytometry, given the expression of CD71, which is an erythroid marker, along with 117 positivity, which defines the early stage erythropoiesis. And these 170 positive erythroid precursors were significantly increased in these very good ESA responders with a sustained response, compared, for example, to non-responders, and also to a group of control age match cases. And then we went through the molecular evaluation, and we first of all dissect this erythroid repartition among the distinct subtype of MDS according to the new molecular WHO classification. And we observed that in the SFTB1 mutated MDS group, there was an increase of the same erythroid, early erythroid precursors, so compared to the other WHO subtypes. But strangely, in this case of specifically SFTB1 mutated cases, there was no association with the response. So we hypothesized that given the effect of the SFTB1 variant on erythropoiesis that leads to an expansion of the immature erythroid population, like, for example, we see in thalassemia or in other erythroid disorders, this is not associated with a response. And in fact, we know that SFTB1 mutated MDS They respond to ESA, but response tends to be shorter compared to other type of MDS. They will develop transfusion dependency earlier in the course of the disease. And this might be explained by other factors, not intrinsically erythroid factor. And this might also explain why luspatercept works, because luspatercept acts on more the microenvironmental factor and on the ligands that we know inhibits erythroid development in the late phase. So we next focused on the non-SF3B1 MDS per WHO, given this association with the expansion of erythroid precursors. And we confirmed what we observed before. So the increase of these immature erythroid cells significantly associated with the response, and also IPSSM. So IPSSM is the new molecular prognosis scoring system for MDS, but its role in evaluating response to treatments is not so well explored, especially in the lower risk MDS. There have been studies that try to assess the prediction to add a treatment or transplant, but not in the lower risk, and especially for ESA. And interestingly, we observed that IPSSM was significantly lower in ESA responders compared with non-responders. And as it happens, the case is transitioning from lower risk categories per IPSSR to higher risk categories per IPSSM, showed very good, very short and reduced response rate. So we thought that by combining IPSSM and these flow cytometric results, we could implement the prediction of ESA treatment at baseline. So we developed, we find the threshold that could discriminate very efficiently responders and non-responder with these two parameters. And with these two thresholds, we identified a subgroup with high IPSSM score, specifically more than 0.25, and low CD170 positive erythroid cells, specifically less than 10.3%. And these are the non-responders. In all our core, they were all non-responders and few short responders, so tend to lose response very quickly. And an important point of this study that all these evaluation and results were confirmed in an external cohort that we collaborated with the Cochin Hospital in Paris that had a similar strategy to analyze erythroid population and comparable NGS evaluation. So yeah, that basically is the story behind this study. So that's a very interesting point, and we also trying to explore, so we're going further to this from a more biological point of view. So for the SF3B1, I think that the model is very well studied because we know that the defects in SF3B1 mutated erythroid cells, it's delayed because it mainly affects hemoglobin synthesis and the iron increase progressively in the mitochondria during erythroid maturation. So the blocks, let's say, will occur lately. And this as a bottleneck effect will create an increase at the beginning. And also by the fact that SF3B1 mutation is a very, let's say, stable mutation, more often isolated or tend to occur with less type of mutated genes compared to other kind of mutation, other splicing factor mutation or other mutation recurrent in MDS. So that might explain the SF3B1 case and this exception to our model. In the non-SF3B1, of course, is a more heterogeneous, more molecularly and clinically than the SF3B1 counterpart. And we observed, because an additional analysis in our study was a genetic cluster analysis, so based on the type of mutation and VAF. Of course, These results need to be taken carefully because only 50 non-SF3B1 in total. So, but still, we observed that were recurrent mutation in the non-responder groups. For example, ADH1 or 2, more 2 than 1, and BCOR, STAC2, A-zeta-H2, which are prognostically relevant because they increase IPSSM, and this is in line with the result that IPSSM is associated with response. But some of them have been shown to have an effect on erythropoiesis. For example, STAC2 induce a myeloid skewing differentiation. It gives the more stamina, so the stem cell remains stamina and doesn't go into differentiation. And if it goes to the myeloid compartment with a significant reduction in the megakaryocytic erythroid compartment, it has been shown in primary cell cultures or in mice. So this might explain why EPO is not working, because you don't have the target population to the substrate to work with. And this might also be the case for others. So it really is a fact that the mutation, of course, is important in driving the phenotype, which we studied with the ontogeny of erythroid precursors. And if you lack the substrate, of course, EPO is not efficient in doing its job. So that might be an explanation, but more studies and research needs to elucidate. So that's the important question from the practical point of view. So hopefully we would like to validate these results in larger cohort and provide additional tool to optimize treatment decision in the first line. Of course, results that will come from clinical trial evaluating luspatercept in transfusion independent and first line will also help in that. But we also need the biomarkers. We also need something that in MDS is lacking, and there's a really unmet clinical need. So in my perspective, I think that in future, molecular information will be very helpful in discriminating ESA responders, no responders, luspatercept responders, no responders, along with the historically known predictor of response like serum EPO, transfusions, because it's completely different setting a transfusion-independent patients from a heavily transfusion-dependent patient, because in the second case, we will never use ESA. We know that they don't work. So we need to combine all these. And of course, the safety profile of the drugs. You mentioned imetelstat. Probably imetelstat will not go beyond the second or third line because of the myelotoxicity and everything. So we need to integrate everything and to understand better the molecular landscape of the patients, and apart from SF3B1, because or the ring sideroblast phenotype. Because SF3B1, okay, but is commutated with what? We know, for example, that it ranks 1 as a worse prognosis, and probably they respond less to luspatercept as well, but also to ESA probably too. So we need to have the molecular pattern more clear if we want to have more help in the decision treatment.